So I'm going to be talking about respiratory infections in general. The big three, of course, being COVID, RSV, and flu that are on everyone's minds right now. But just starting with a little introduction, because this is a really important concept and becoming more and more important as we see more antibiotic resistance. But just briefly, let's talk about the difference between a virus and a bacteria, because those are the primary causes of respiratory infections. Virus is not actually able to reproduce on its own, so it's not really a living creature, but it's an infectious particle that takes over the host cell, whatever that is. But if it's in a human, it takes over the host cell machinery to just make more of itself. It's just made up of DNA and RNA inside a little shell called a capsid. Sometimes they have envelopes around them, and they're extremely diverse, different shapes, structures, sizes. They infect all kinds of different hosts. So not just humans, but all kinds of animals as well. And they reproduce by infecting their host cells and basically reprogramming them to make a little virus factory. But a key point is they're not considered living organisms, unlike bacteria. So here's a few examples. You can see that's an influenza virus. This is an adenovirus that causes a lot of common colds and other kinds of viruses. So all different kinds of shapes and sizes. And there can be many different types of viral infections, not just respiratory infections, obviously, but those are the ones that probably are the most common. And they include the common cold, which is rhinovirus, and other kinds of viruses like adenovirus, COVID-19, influenza, respiratory syncytial virus, for which there was a new vaccine last year, parainfluenza, human metapneumovirus. So many different kinds of viruses. And we're getting to know a little bit more about the prevalence of these viruses because we have sophisticated testing now. Used to be you came in and we said, well, you have the flu or you don't have the flu. Otherwise, we don't know what it is. But now we can at least often put a name to it, even if we don't have a treatment. A lot of digestive system infections, rotavirus, particularly in kids, hepatitis, norovirus is really getting more and more common these days, and it's sort of spiking up a little bit now. And norovirus has been around for a long time. It's really uniquely contagious. It just takes just a few particles of virus to infect people. It can be food contact, but it causes typically pretty severe but very self-limited 24 to 48 hours of nausea, vomiting, and diarrhea. We're seeing pretty high rates of that now throughout the year. And again, we have panels that can test for this. Although, like many of these viruses, there is no real treatment for it, but fortunately, it usually gets better on its own. These so-called viral hemorrhagic fevers, which we don't see a lot of here, everyone's heard about Ebola. Dengue is something that typically was confined to the tropics, but we're starting to see cases in the United States, and that's probably due to climate change as the mosquito vector is able to move further and further north. Things like yellow fever, which we have vaccines for and are typically not seen in the United States. Of course, sexually transmitted infections such as HIV, human papillomavirus, herpes, hepatitis, and mpox, which came on the scene 2 or 3 years ago. There's rash-causing infections like chickenpox, measles, mpox, rubella, fist disease. Some of these seen mostly in kids. Neurologic infections like West Nile virus. You may have seen that Anthony Fauci had West Nile virus recently and wrote about it. And people can get pretty sick, particularly the older they are. But fortunately, again, symptoms are fairly mild usually, and self-limited polio and rabies, and then some congenital infections. So these are all different kinds of viruses, and that's just a small sampling of them. How do you get them? Coughing, sneezing, close contact. Fortunately, COVID in the beginning, everybody washing their groceries down, we thought that you could get it through contact, but that's much less likely with COVID. But with flu and other cold viruses, masking can help, but it's not quite as effective because you can get it just through particles that are on something that someone has touched. You can get viruses transmitted through sex, bite from an infected animal, such as a mosquito or a tick, Lyme disease, or from eating contaminated food or swallowing contaminated water, such as hepatitis or a virus, as we mentioned. The best way to present viruses viral infections are vaccines where they exist. So we have lots of vaccines now: RSV, flu, COVID, chickenpox, measles, mumps, rubella, polio, hepatitis A and B, HPV, meningococcal meningitis, shingles. Those are all vaccines that are available. I know there's a lot of vaccine fatigue in people, including myself, and some of these may be more important than others, but it's important to try to stay up to date. Wash your hands frequently. This is important with COVID, but it's very important with cold and flu bugs. So just get in that habit of washing your hands a lot. Safe food habits. Fortunately, not as important here, but we do see food outbreaks in the United States, particularly undercooking meats and poultry. Using condoms or dental dams during sex, protecting yourself from bug bites, paying attention to the West Nile virus season, which we're sort of moving out of. Don't get near aggressive animals, pretty obvious one, and avoid other people who are sick. And there are some things where you can get post-exposure prophylaxis, such as rabies, HIV, hepatitis B, or chickenpox as examples. So if you think you've been exposed, there are infusions you can get or shots that can help you prevent getting that if you don't have immunity. But hopefully people are vaccinated for a lot of these things. We do have treatments for a lot of viruses now. When I first started in medicine, we really didn't have many treatments at all for any of these things. But now we do have drugs available for flu, obviously for COVID-19, for both hepatitis B and important hepatitis C, which was extremely hard to treat a couple of decades ago, but now has highly successful treatments. And everybody should be tested at least once for hepatitis C in their lifetime. Obviously, treatments for HIV, treatments for Mpox, the herpes viruses, HPV, and for CMV. We do have a lot of medications now to treat some of these viruses, although things like the Ebola virus, we just treat symptomatically. So what are bacteria? Bacteria are living organisms, but they only have one cell. There's millions, if not billions, of different types of bacteria that can be found all over the world, including in our bodies. We have bacteria that live on our skin, in our airways, our mouth, digestive system. We have many, many bacteria, reproductive system, and urinary tract. They think that you may have 10 times more bacterial cells than human cells, and that's saying a lot because we have a lot of human cells. So there are many bacteria that live with us and may have a beneficial purpose, but some can cause disease, particularly if things get out of whack. If the pH in the vaginal canal gets a little out of whack, you can get a bacterial vaginosis. If you take antibiotics that kill some of the beneficial bacteria in your gut, you can have overgrowth of bad bacteria and so forth. And they can be found everywhere: soil, water, plants, the Arctic ice. They've dug up influenza from the great influenza epidemic of 1918 in the ice. So bacteria really are everywhere. Respiratory infections, they often cause very similar symptoms: cough, fever, aches, runny nose, and so forth. But the important thing to understand is that antibiotics do not help treat viral infections. It can sometimes really be difficult to tell, but the vast majority of infections, particularly during the wintertime, are viral infections. And usually they're going to get better on their own. Like I said, we can test for some of these things that may have a treatment. But one of the reasons people often think that antibiotics do treat viral infections is because you get sick, call your doctor, you ask for antibiotics, you get antibiotics, and 5 days later you feel better. But the likelihood is that 5 days later you would have felt better anyway. And the antibiotics really didn't do much, and they can do harm. So there's really a push now to try to avoid overuse of antibiotics, to avoid developing resistance and the harms that they can cause to you individually. Even short-term courses can cause these diarrheal infections. It's sometimes hard to tell, but it's important to try to distinguish that in talking to your doctor. Testing for flu and COVID can be helpful because we can treat them. And as I said, we do have a lot of tests that can distinguish these now. Respiratory syncytial virus, in many ways we didn't hear too much about it because there wasn't a vaccine for it until recently, but it was actually first discovered in 1956. So it's been around for a very long time. Very young babies are particularly at risk, particularly if they're premature, and then folks in their 70s and 80s, particularly who have other illnesses such as heart and lung disease. As I said, we didn't really have a test for it or a vaccine until fairly recently. So it was just something that we treated symptomatically. Fortunately, again, usually the symptoms are pretty mild and they're sort of like cold. You don't necessarily even need to be tested for it. But a vaccine did come around last year. Now, initially, they recommended it for anyone over 60. They refined that a little bit. There was a little bit higher incidence of something called Guillain-Barré syndrome, which we can see with all vaccines. It's a neurologic problem that can happen after vaccines. And I think partly based on that, they refined their recommendations. There's two right now. One of them is recommended for pregnant women. They have a little part of the RSV virus and just give you an immune response to protect you. And so the recommendations now, if you're 60 to 74 and have a weakened immune system from other illnesses such as leukemia, HIV, or you have underlying lung disease, COPD or asthma, or if you're in a nursing home, that it's probably a good idea to get it. But everyone over age 74 is recommended to have one dose of the vaccine. And pregnant women should get it between weeks 32 and 36 pregnancy. They're pretty effective, to 83% effective. In the studies during the second season, they were still fairly effective, and the same for the other vaccine. Like some vaccines, the protection probably does wane a little bit over time. Right now, I think they're recommending that you get the vaccine once. That may change as time goes on. There is an injectable medication called nirsevimab that is strongly recommended for infants younger than 8 months of age who are born during or entering their first RSV season. So right now we're getting into RSV season. If mom didn't get an RSV vaccine during pregnancy herself during those 32 to 36 week period, or if they don't know if they got a vaccine, or if the child was born within 14 days of the vaccination, so prematurely, if the mother was vaccinated appropriately, the child usually will not need to get this, but it's shown to be highly protective, and it can be a very severe disease in infants. So this is a real advance in preventing RSV infection in young kids. Some infants and young children who are 8 through 19 months of age that are at increased risk, maybe they didn't get the injection at birth, but if we're coming into another RSV season, the pediatrician may recommend, depending on their health status, for them to get it as well. It's just a shot in the thigh muscle, and it's a single dose during RSV season. Here it showed that it reduces the risk of severe RSV disease in infants by about 80%. So that's pretty dramatic. Protection for up to 5 months, which is about the length of the average RSV season. Unlike a vaccine, it doesn't activate the immune system. It's a little more like those monoclonal antibodies that we reuse to treat COVID. So it's really most effective in the weeks right after the injection. It doesn't give you long-term protection, but it's important when they're most at risk. So that's something that's really been rolled out very effectively in the last couple of years. This is last year's flu season. We don't know what the peaks are going to be, but it's likely the timing is going to be a little bit similar. This was the COVID peak. Last year in the summer, we also had a COVID peak. It was actually the second highest peak after Omicron this year, starting in around May or June and going through the summer. There was that summer peak and then a second peak. And you can see last year, really started to pick up again more towards November, December. Flu also started to pick up November, December, and that's usually a pretty good bet. So getting your shots now is a good idea. RSV starts a little bit earlier, usually September. We're at pretty low levels right now, but we may see that pick up. So this is kind of a typical pattern year to year, and I think we can expect something similar this year, although we don't know how high the peaks will be. And I wanted to mention this. COVID testing has gone down dramatically. I do test occasionally in the office. If someone comes in with respiratory symptoms, I'll do the old nasal swab and PCR, that swab that everyone hates that feels like it's going into the back of your brain. But a lot of people are doing rapid tests at home and not reporting it anywhere. So we can't really get a great sense of incidence based on testing, and a lot of states aren't really reporting that anymore. So wastewater has become kind of a big thing. And this is a slide from this site here run by the CDC. And you can look at any time period, you can sort it by states, you can look at RSV, COVID, flu, and other viruses. This is probably going to be the way moving forward that we get a little bit of a sense. Now, there's going to be a little bit of a lag. When RSV starts to pick up in wastewater, we may later start to see cases coming into the hospital, but it's going to be a pretty good sense. You can see here that cases tracked pretty well. This is national and this is states, but right now here in September of this year, there's very little RSV in the wastewater in New York. This is a slide from New York. And this is COVID-19. The orange is New York, black was national. And you can see how there was a big spike last winter. And then this picked up that summer spike that we had in the wastewater. So wastewater is going to be a better way. It's not ubiquitous. There are some states that only have one or two wastewater monitoring stations. Some states have more coverage, but it's a decent way. So when you hear about that, they're literally testing the wastewater at treatment plants, looking for a whole panoply of different viruses. And this slide is just to show that respiratory diseases in general are more dangerous to the very young, and then the older we get, the more susceptible we are. So again, very important to get those vaccines at an older age. I wanted to include a little bit about bird flu because I'm sure people have heard about that and may have some concerns about it. We have had bird flu in the past. It's a little bit alarming because people tend to get sicker and there's a higher mortality rate with bird flu. The current bird flu is H5N1. It's been widespread in wild birds worldwide. It's been found all over. And of course, I'm sure everyone's heard about the outbreaks in poultry here in the US as well as dairy cows. There have been human cases in dairy and poultry workers. Right now, the CDC feels like the risk to the public is low. There have not been any documented human to human transmissions, and that's super important. They're using flu surveillance to monitor for H5. It's influenza type A. And so when people test positive for influenza type A, they can submit it. It's not routine testing that we can do in the hospital, but some samples can be submitted to the CDC for full typing. There have been, as of a few days ago, 18 human cases. They've, as I mentioned, been in cattle and poultry workers. There's this one I circled that was in Missouri where they are not sure. As far as I know, they haven't yet typed the N part of it, so they know it's an H5 virus. And there were healthcare workers that were exposed to this patient who were sick around the same time, but none of them were felt to have the H5 virus. So that case is an ongoing investigation. But the vast majority of the cases, and there have been a handful, have been in cattle and poultry workers. The symptoms are typically pretty mild. No one has gotten seriously sick. This patient in Missouri was hospitalized, but did okay. Usually some conjunctivitis, inflammation of the eyes, and some cold symptoms. So what can we do? Like I said, try not to worry. At the moment, it's not felt that the risk of human-to-human transmission is high right now. As I mentioned, the cases have been pretty mild. There are 2 candidate vaccines for H5N1 that are being stockpiled by the government. There's about 100 million doses that are in storage and are ready to roll out. Should there be any evidence of human-to-human transmission, they're working with Moderna. It's one of the companies that produced the COVID vaccine to develop an mRNA vaccine for H5N1. And of course, you can get your regular flu shot, which probably isn't going to offer a huge amount of protection for this, but will prevent you from being sick with both certainly at the same time. We also have medications stockpiled. The current flu medications are somewhat effective against H5N1, but it's a situation that's being monitored closely. And right now, the feeling is that human-to-human transmission risk is low. In the future, we really need an upgrade to influenza vaccines. Everybody's sort of tired of getting them every year. It's a little bit of a guessing game as to what's going to be circulating in any given flu season. They have to make the vaccines in advance of the flu season based on what's happening in Asia or Australia, and guessing what might be circulating here in our winter. It's very labor intensive to produce these vaccines. So they're working very hard on so-called universal vaccines that, rather than targeting the part of the virus that changes every year, targets the part of the virus that doesn't change every year. So that would be something that, again, they're working with this newer mRNA technology that someday soon, hopefully we could just get one vaccine and perhaps not need it annually. But for now, get your flu shot every year, particularly if you're older or if you have other health problems. COVID, many lives lost, was a huge drop in life expectancy across the world, just simply based on COVID. The good news is that death rates, the incidence of long COVID, are much lower now, and they're definitively proven to be lower in people who have been vaccinated versus those who aren't vaccinated. So it's less likely to get sicker and less likely to have long COVID if you've gotten vaccinations. Being vaccinated also prevents some of the cardiovascular complications that you can get from COVID, such as pulmonary embolism or clots in your legs, strokes. So again, vaccines can be preventive, not just in the short term in terms of getting sick, but preventing complications down the road. Paxlovid is still kind of being underused, but it also is pretty effective, again, particularly in older age groups, of reducing your risk of hospitalization and serious illness or long COVID. So maybe not as effective in younger group, but for those who are older, definitely something to think about. This was new earlier this year, and I just like to talk about it because we get a lot of questions about, well, what am I supposed to do now? I have COVID, recommendations have changed. I think it's still important to use common sense, but we have to blend that with reality. Not everyone can stay home for 10 days. Not everyone needs to stay home for 10 days. The guidance right now from the CDC is sort of supposed to encompass any kind of respiratory virus. You get sick with a cold, what should you do? The recommendation is that you can return to your normal activities, regardless of whether it was a cold or COVID or flu, if for at least 24 hours, your symptoms are improving overall. And if you did have fever, you have had no fever for 24 hours without using Tylenol or something else to reduce it. So both things have to be true, improving symptoms and no fever for 24 hours. The definition varies. Again, this is where common sense comes in. If you're feeling better and you don't have any fever. So it's not necessarily that you have to stay home for 5 days. If you're sick for 2 or 3 days and you're feeling better, most people still recommend wearing a mask for at least another 5 days, particularly if you're around people who are at high risk. Many of us are still wearing masks here at the hospital when we see patients, particularly during COVID spikes. One good way to know if you've had COVID, if you're not infectious anymore, is if you have a negative rapid test, because about 1 in 3 people can still be transmitting COVID 5 days after symptom onset. So again, important to think about masking, even if you're feeling better. So that's sort of where things are now. And if you have questions, talk to your doctor. The bottom line about having this sort of universal guidance is to make things easier. It sort of covers all respiratory viruses. They did look at this, and using these guidelines, they've looked at states where letting people essentially get back to their normal activities sooner has not caused huge amounts of ongoing forward transmission. And this was from Catalina Gentilina, who has a nice website, your local epidemiologist, and a newsletter that comes out that's free that gives you updates on that. So it seems to be a pretty safe strategy rather than the old isolate for 10 days. Some people may hear that if I don't have a fever, I can go out, but remember, you should also have your symptoms be improving. I think it is important to wear masks for a while longer after you're sick. Employers obviously are pushing people to come back to work, and that can be a stressful situation. So depending on your situation, if you're able to isolate for longer and able to test yourself towards the end of the infection, just to make sure that you're negative, you can do that. But I think a good rule of thumb is isolating until you're feeling better and wearing a mask for the next few days, mainly to protect others. What else is new? There is a new booster this year. Again, it was designed for a variant that was circulating 6 to 9 months ago. It still seems to have pretty good coverage. The virus has changed. It's still in the Omicron family, but they're really recommending that everyone get a fall booster. We're understanding a little bit more about long COVID, but still not any successful treatments. I mentioned wastewater tracking has become very important, testing decreasing. We here at our hospital and other hospitals are using the red, yellow, green method. This summer we were on yellow, which meant that the staff and visitors should be wearing masks. Red would be the highest, where they may limit visitations. Green means that it's optional. We still wear masks when we're seeing high-risk patients. But vaccination and treatment, if you're high risk, are the most important things that you can do. Right now, there's the Moderna, which is the 2025 version, the Pfizer, and then the Novavax, which is approved for 12 and older. So what can we do this fall? Get your flu vaccine. People over 65 should use the somewhat stronger dose of the vaccine. RSV vaccine, optional for 60 to 74, but if you're at high risk, consider it. Definitely for pregnant women, and you should get it if you're over 74. The COVID vaccine, if you just had COVID infection a month or two ago, you can wait. It's certainly safe to get a vaccine soon after an infection, but you probably have some protection for a few months after infection. So just in terms of extending your protection, you might as well wait a few months before getting it. So that's where we are with the recommended vaccines. I will also say that whooping cough, which is Bordetella pertussis, which is a bacteria, is making a comeback. Again, that's something that often affects young kids, but adults can get it as well. Most of us get a booster every 10 years along with our tetanus shot. There's a shot, it's called Tdap, and the P is for pertussis. So if you have not had that Tdap vaccine in 10 years, you should definitely get that. Sometimes you go to the emergency room when you stepped on a nail, and they give you just the tetanus alone. That doesn't include the pertussis. So make sure you talk to your doctor and that you're up to date with Tdap. I think there's a fourfold increase in whooping cough cases this year compared to last year. And it's something we really rarely saw up until now. And it's, again, I think because of both vaccine fatigue and vaccine skepticism that we're seeing. Unfortunately, the symptoms are pretty similar amongst flu, COVID, RSV, and other cold symptoms. Some things like severe muscle aches maybe are a little bit more common with flu than they are with COVID or RSV. Certainly losing your sense of taste and smell is more COVID. Congestion may be more common with RSV, but really there's a lot of overlap. Talking to your doc or getting tested is the way to go. We can differentiate on testing between these three. That can be important because we do have medication for flu or COVID. During the flu season, oftentimes if someone call me, they tell me that they have symptoms that are really pretty classic for flu, particularly those really strong body aches, fever, and chills. Maybe they've done a rapid test and they know it's not COVID-19. Oftentimes we won't even have them come in to test. We'll just treat them with the oral medication for flu. So you don't always need to get tested. There's now rapid tests that include flu. They're a bit more expensive than the COVID tests, which are expensive enough, but there are some home tests now that can differentiate for flu as well.